Okay, we'll get started, and we're going to talk about normal white cell morphology. So in lecture 1, we talked about the maturation of our white cells from the pluripotential to the multipotential stem cell through other progenitor cells until what we term blast. You guys haven't seen that yet, but you're going to get to know the blast very well up to the prophase and then all the way up into our normal mature cells that we see in peripheral circulation. All right, so just remember that our pluripotential stem cells will become those committed multipotential stem cells based on those colony stimulating factors, those cytokines. And remember those progenitor cells, those stem cells, they all look the same. We are unable to visually distinguish them, okay? Up until the blast phase. The blast is the first cell that we can distinguish visually on using our Röntgen stain. Okay, so after maturation, the cells are going to remain in the bone marrow for several days before they're released into the peripheral blood. Remember that our white cells, the niches that we talked about in the cord within the bone marrow, the white blood cells kind of tend to hang out on the inside. As they mature, they migrate toward that adventitial cell lining and the epithelial cell lining. And then they will squeeze their way through into the circulation, into the sinus, capillaries, and then into peripheral blood circulation. All right, so remember, you might see this question pop up. Why does the bone marrow have more white cells than red cells? Exactly. Your white cells do not live as long as your red cells. So the bone marrow is constantly producing white cells to maintain a steady state, a steady supply for the body. All right. And when we start talking about bone marrow analysis, we're going to talk about the myeloid cells to erythroid cells ratio, all right? So your myeloid, the normal ratio is 3:1. You guys don't have to know that right now, but eventually you will. But that's why. I know a lot of information is thrown at you guys, and oftentimes as a student, I always ask why. So I try to give you reasons behind the way things are. That's one reason I think I talk too much. Okay, so when you think about white cells maturing and entering circulation, we actually have two pools of white cells. All right, we're going to have what we call the marginating pool. They're going to enter circulation, and they're going to kind of hang out in the epithelial lining of the vessels. They're just going to kind of hang out there until they're needed. All right, and that's called margination. That's the marginating pool. The other one, after diapedesis, they will be actively circulating in our circulation. So during our CBC, when we measure our white cell count, we're really only measuring the circulating white cells. We're not measuring the marginating white cells. Does that make sense to everybody?
What was that again? Repeat what you just said.
So the marginating white cells, they hang out along the endothelial cells of the vessels. They're marginating right there. They're just kind of hanging out, all right? They're just kind of waiting in case, ready to respond in case the body needs them. Okay? Versus one other type of pool, they're actually circulating. They're traveling through the peripheral circulation system. That is the population that we measure. Okay? Does that make sense to everybody? So you have some marginating white cells, you have some circulating white cells. Both of those will eventually diapedese into the tissue where they will be destroyed, whether that be the spleen, and then they'll be taken out. All right, so 50% circulate in the blood. And again, these are the ones that we actually measure during the CBC. And then 50% live as marginating cells. Again, they're just waiting to respond, such as an infection, any type of inflammation. One of the things during any type of inflammation, damage to a vessel, those white cells are going to respond. Cytokines are going to be released. We're going to talk about the process of phagocytosis, and the marginating ones will respond in that instance as well. And again, these white cells will eventually travel to the tissues where they will be destroyed. Remember, white cells do not live very long. I think like 15 to 20 days is their max. So, and they're in the bone marrow for the first 5 to 7 of those days, all right? So you probably only have 4 to 5 days that they're actually in circulation. And those white cells, once they enter the tissue, they never return back to the circulation. They'll be destroyed. Okay, so when we think about white blood cells, we think about their maturation sequence, there are some things that we're going to look for in classifying these white cells. All right, number one, think about those immature cells, and if you look at that chart I gave you, we're going to look at cell size. So at the blast phase, the cells are very large, all right, and as they mature, the cells are going to get smaller in size. So one thing we're always going to look for is cell size. We're also going to look at coloration of the cells. Our immature cells are going to have like a bluish or basophilic tinge to them, right? And as white cells mature, they tend to get a more grayish, that blue tinge will go away and it tends to become more of a grayish color, all right? And we're also going to look at the nucleus. We're going to look at the chromatin clumping within the nucleus, right? So our blasts, very immature, they're going to have a very fine, very not condensed chromatin at all, right? As the cell matures, the nucleus is going to get smaller. It's going to become very condensed, and all of our cells have very specific nuclear chromatin condensing, I would say. We're also going to look at the presence of granules, all right? So we talked about our granulocytes, our basophils, our eosinophils, and our neutrophils, right? So those from the myeloid cell line, all right? And primary granules will be the first granules that are able to be seen, right? And we will see primary granules in our promyelocyte. And they appear as purple reddish granules. And we're going to talk about the contents of those granules later on and their purpose. Secondary granules, all right, so you'll have some primary granules in the promyelocyte, and then at the myelocyte phase, we'll start to see some secondary granules form. And then these granules, the primary granules tend to decrease as the cell mature. There's also a third type of granules. They're called tertiary granules, but we cannot see them with our staining techniques. You will not be able to see them. So we don't spend too much time talking about them because we can't see them. All right, so if you take a look at our granules, each of you take a look at your chart, look at what a segmented neutrophil looks like, look at what a eosinophil looks like, and look at what a basophil looks like. All right, so take a look at your eosinophil. It is known for the bright orange granules. Does everybody see that? It has to do with how it takes up the stain. So the eosinophils are very acidic, so they're going to take up our eosin stain. And so that's why they have a more orangey tinge to them. Versus take a look at the basophil. Notice that basophil is predominantly covered with dark purple granules. All right, so it is primarily going to take up our Giemsa stain. All right, it's going to take up, so it's very dark. Versus our neutrophil, it has a neutral pH, so it is actually going to take up both the Giemsa stain and the eosin stain. All right, so that's why it's called a neutrophil, because of that neutral pH, and it stains very neutrally. And at the end of this lecture, we're going to talk about the right stain, the right Giemsa stain.
So is the basophil basic?
Yes.
And the eosin.
Yep. Does everybody see the difference between a basophil, eosinophil, and a neutrophil? You guys are actually going to look at these in lab this afternoon, so you'll become very comfortable with them. All right, so I mentioned that we always look at our nucleus of each cell when we're trying to classify a cell. All right, so as the cell matures, that nucleus is going to reduce in size. The chromatin is also going to condense, right? And that nucleus is going to have the more immature cells, such as our blasts, is going to have a very fine chromatin. And we're going to look at some pictures, so this will make sense to you in just a minute. Very fine chromatin, and as the cell matures, that nucleus chromatin is very clumped, very condensed, right? We're also going to look for the presence of nucleoli, all right? So for our myeloblasts, it's very common for like 4 to 5 nucleoli to be present. As the cell matures, those nucleoli will start to disappear. So when you're trying to classify between a myeloblast and a promyelocyte, you can look at the presence of nucleoli. So if you have 4 to 5 nucleoli, no granules present, it's probably a blast. Versus a promyelocyte, you have some granules, maybe you have less nuclei, maybe 2 nuclei, then it's going to be a pro. All right, so those are some of the things we can do to classify the different types of cells. In lab, when you're trying to tell me that you have a pro in your field of view, promyelocyte, I'm going to ask you, why are you calling it a pro? If you can defend yourself, I will give it to you. So as we are doing this cell identification, we're looking at colors, we're looking for the presence of nucleoli. You can imagine how subjective this is, right? So what I call a pro, you might call a myelocyte. So there are some subjectivity. So if you can defend your answer, I often will give it to you. Now, if you say a mature erythrocyte is a blast, of course, that's not correct at all. But differentiating between a promyelocyte, a myelocyte, and a metamyelocyte, if you can provide some reasoning behind your answer, I will often give it to you, all right? There's subjectivity with this, and that's why flow cytometry has really enhanced the hematology field. Does that make sense to everybody? And then even, like me as a seasoned hematologist versus what, Angie works in hematology on a daily basis, there's some variety. There's some differences between what I call and what she calls. And so we accept that. We acknowledge that. The big thing is that it's immature. And you say, oh, I have granules, I have nucleoli, the nucleus is very fine, it's not condensed. All right, so you have to be able to back your answer up. Right? And you guys will be pros at that in lab, because we'll talk about it again in lab too. All right, so we're also going to look at the shape of the nucleus. All right, the nucleus as the cell mature changes. So as a myeloblast, the majority of that cell is comprised of nucleus. All right, so that nucleus has a 4:1 nucleus to cytoplasm ratio or greater. So most of the cell is going to be composed of nucleus. As that cell matures, the nucleus is going to become smaller. It's also going to start changing shapes. When we get to our metamyelocyte, the nucleus is going to start having like a indentation, almost like a kidney bean shape. And then when you get to the metamyelocyte, that shape is even more pronounced. Okay. And then, like I mentioned, that myeloblast is going to have a high nucleus to cytoplasm ratio. Most of the cell is going to be comprised of the nucleus. As that cell matures, we're going to have more cytoplasm, less nucleus. Okay. And like I mentioned, those white cells are going to take most of their time in the bone marrow. It takes them a while to mature. They're only in circulation for a short period of time before they'll travel to the tissues and be destroyed. That's why the bone marrow has so many white cells. And again, the neutrophils, that's why we have the predominant number of neutrophils, is because it is involved in our process of phagocytosis to respond to bacterial infections. Okay, so let's go through each of these cells. This is your myeloblast, right? In a normal situation, we will only see a myeloblast in the bone marrow. If you see a myeloblast in your peripheral blood circulation, that means there is a leukemic situation going on, all right? Such as acute myelocytic leukemia. So in normal situations, we will not see myeloblasts in the peripheral circulation. All right, so notice your nucleus, round and oval. The nucleus chromatin is very fine. It's not condensed at all. Notice that your nucleus takes up the majority of the cell, right? So here's your, and I apologize if the screen prohibits the images. Notice that your nucleus comprises most of the cell, right? So that high nucleus to cytoplasm ratio. And notice that you have the presence of some nucleoli. So there's one there, it might be hard to see in this image. Definitely a nucleoli right there. Guys see that? All right, so you have presence 2 to 5 nucleoli. Notice that your cytoplasm, again, most of that cell is nucleus, and your cytoplasm is like a blue-gray. All right, so I have a caveat to this. We always train our students that myeloblasts do not have granules. All right, that's one way to differentiate a myeloblast from a promyelocyte. However, if you read your textbook, there are different types of myeloblasts now. They're divided into 3 types: type 1, type 2, and type 3. Type 1 myeloblasts do not have any granules. All right. Type 2 myeloblasts can have the presence of, I think it's like 10 to 20 granules. And then type 3 has like lower amount of granules. You guys don't have to know that. All right. For all our purposes, when we call a blast, I want you to find a cell that has very fine chromatin, no granules, and the nucleus composes most of the cell. Okay. Now, so when we start looking at some of our AML patients are abnormal. These cells are being produced abnormal. It is probably, you're going to find some blasts that do have some granules in it. I don't want that to shock you. That shocks some students because they're like, oh, it can't be a blast because it has a few granules. So don't be surprised if you enter your internships or flow cytometry will call a cell that looks like a blast that has granules, they're going to call it a blast, or you might have called it a pro. All right, so you see how there's some subjectivity there. All right, but I don't want you to memorize type 1, type 2, type 3. You don't have to worry about that. For our purposes, blasts do not have granules. All right, does that make sense to everybody? I just don't want you to be thrown off when I tell you blasts don't have granules, but then you read somewhere, textbook, an article, and they're saying blasts can't have granules. They can, and they probably will in an abnormal situation. Right? But if you encounter a cell like this in a normal bone marrow, probably not. Does that make sense to everybody? All right, so then you have your promyelocyte. And again, we should only see this in the bone marrow. All right, it is not normal to have promyelocytes in our peripheral blood circulation, except for in the case of a leukemic state, or if it's a very severe infection. And we'll talk about that too. All right, so it is actually about the size of a blast. I know I said that as cells mature, they decrease in size, but our pro can actually even appear sometimes larger than the blast. You might even encounter that. And notice our nucleus. Notice the big difference in our nucleus. All right, take a look at this cell. See how most of the cell is comprised of the nucleus versus the pro. All right, our nucleus is getting smaller. It's condensing a little bit. And what do we have? What are all these little purple spots? Those are granules. What type of granules are those? Primary or secondary? Primary. All right, so we will begin to see our primary granules in your promyelocyte. Right? Primary granules, promyelocyte. There's your connection. Okay. And you should see the number of nucleoli start to decrease as well. Sometimes it's very hard to tell with nucleoli, though.
Is that what the arrows are?
The arrows are actually pointing to your nucleoli, yes. Okay. So sometimes your nucleoli, depending on how they take up the stain, they can appear as these clear areas right here. So that's the nucleoli. Or they might even appear as a little bit darker areas. It just depends on how the cell landed on the slide and then how they take up the stain. Notice we have more cytoplasm in the cell. Again, our nucleus is getting smaller. And then we have our primary granules. Another word for primary is nonspecific. So primary granules are nonspecific, secondary granules are specific. And the reason behind that is when you get to your myelocyte, the myelocyte is the first stage of maturation where we can tell this cell is going to be an eosinophil, a basophil, or a neutrophil. All right, based on the type of the secondary granule. So if it's going to be a basophil, where secondary granules are going to be very prominent, all right, and they'll have a more darkish purplish tinge to it. If it's going to be an eosinophil, guess what? Those granules are going to be very orange. And you guys will see this when we start doing bone marrow analysis. We'll see some myelocytes that have eosinophil granules. And if it's going to be neutrophil, this is what it will look like. These granules here. Okay, so this is your myelocyte. Again, normal situation only observed in the bone marrow. And again, notice, take a look at your promyelocyte. All right, take a look at the nucleus versus your myelocyte. Our nucleus chromatin is still condensing, right? It's getting a little bit more clumped with each maturation stage. All right, so the myelocyte, let's see if I have a better picture. The myelocyte has a specific characteristic to it. See this perinuclear clearing right here, right outside the nucleus? That is called the dawn of neutrophilia. So that is one characteristic trait of a myelocyte. So if in bone marrow analysis you're like, oh, I'm not sure if that's a promyelocyte or a myelocyte, if you see this dawn of neutrophilia, it's a myelocyte. Right? That's one characteristic. Dawn of neutrophilia. Yes. I think it's like a Golgi apparatus during the cell development process. All right, so notice that the myelocyte, this is our first stage of maturation where we should have no nucleoli present. No nucleoli. And then we'll also note, we'll start to see primary granules and secondary granules too. Those secondary granules are very prominent and they oftentimes will mask the primary granules. It's the myelocyte I said that we can tell eosinophil, basophil, right? I said myelocyte, right? Okay, just want to make sure I didn't get ahead of myself. All right, and then the cytoplasm, notice that it becomes less blue, right? So remember, our cytoplasm is also maturing, so we're getting more to that grayish coloration right now. And the myelocyte is actually the last cell to divide, right? So no more mitosis, yeah. All right, so we have our myeloblast, promyelocyte, myelocyte, then we have our metamyelocyte. And you guys have to know the order of maturation, right? It's very important. The white cell is pretty easy, pretty straightforward. When we get to the red cell maturation sequence, a little more complex. We have some different languages. So the red cell maturation sequence is a little more complex, but all right, so our metamyelocyte, it can be observed in the bone marrow, or we could even see it on the peripheral blood. All right. If a patient has an infection and they have an increased need for white cells, and that bone marrow is going to be pumping out white cells at a rapid pace to respond to that infection. It's what we call a left shift. So your white cell count is going to go up. You're going to have the presence of immature white cells. So usually you won't have anything more immature than a metamyelocyte present, though. So no myelocytes, no promyelocytes, and no blasts. Usually if those three are present, it indicates a leukemic state. All right, so we're decreasing in size, so this cell is smaller. Notice that the nucleus starts to change shape. It has a very characteristic, you can call it like a kidney bean if you want to. It starts to have this indentation right here. And look at the clumping. The chromatin is becoming more condensed. Starting to look darker if you want to think of condensing as darker. And you should have secondary granules. They should become more prominent as the cell matures as well. It's hard to tell in this image. It looks better for you guys actually than mine. So here's your granules. Little specks, those are your granules on top of the cytoplasm. Okay, so there's a huge controversy over what we call a neutrophilic band. All right, so a neutrophilic band, the nucleus is completely like this, often described as a C-shaped. All right, so this is the next maturation stage after the metamyelocyte. And then oftentimes you'll see it curved like this. So this is a neutrophilic band. Again, the cell is smaller. The color of our cytoplasm is changing. It is now kind of that pinkish coloration that we typically see in a mature neutrophil. And this is it is normal to see up to 5% of bands in peripheral circulation. All right, so remember I said that controversy. So here is a perfect example of what a banded neutrophil looks like. Notice the difference between, this is a segmented neutrophil. Call this one a segmented neutrophil because of this visible filament right here. A segmented neutrophil is termed segmented because the neutrophil is broken into segments by visible filaments. Notice this one has no filaments, right? It's a solid nucleus. Right, so this is a segmented neutrophil. You can see the filament. A banded neutrophil. And again, normal to see banded neutrophils in peripheral circulation up to 5%. Okay. Sometimes you won't see any bands on when you do a 100 cell differential. That's okay. Sometimes you might see banded neutrophils. You might even see an increase in them, again, in the event of an infection where those cells are being pumped out from the bone marrow at a more rapid pace. And then we definitely see these little dots right here. Those are your secondary granules carried over through the maturation sequence. All right, so here's a happy little seg. You guys might encounter some of these in lab. And so we harp on you guys that no cell phones are allowed in lab. However, I know we will have some fun stuff. You'll see some interesting cells. If you want to take a picture with your cell phone, I allow that. You can call me over. I will help you focus in through the oculars. We can take a picture with your cell phones, okay? But just don't pull your cell phone and you have to take your gloves off and wash your hands and then get your phone out, okay? But students, you might see a cell like this, a happy face, and want to post it on Facebook or whatever. I have no problem with that. I can help you. We even have an apparatus that covers up one ocular, so you can just concentrate on one and hold your cell phone there and you can snap a picture. So I'll help you focus that if you guys ever encounter an interesting cell. You might see a myeloblast. You want to take a picture of that. For some people, like to take pictures for study. I had one student like, can I take a picture of this so I can look back and know that this was a myeloblast. So I'm totally okay with that again. Just take the gloves off, wash your hands before getting your phone out. All right, so our segmented neutrophil, like we mentioned earlier, is involved in the process of phagocytosis. It will actually engulf and destroy bacteria. And we will talk extensively about the process of phagocytosis in a future lecture. And I mentioned earlier the normal range for segmented neutrophil. Again, this is our ultimate mature cell. This is the most mature our myelocyte is going to become, all right? 50 to 70% is our normal range. And again, because it is the most mature cell, it is smaller in size, right? If you put a segmented neutrophil next to a myeloblast, myeloblast being the most immature, the myeloblast is going to be significantly larger, right? So your segmented neutrophil is smaller in size because it has gone through the maturation sequence. Again, it is considered a white cell. It's a granulocyte. It's capable of diapedesis, and again, very involved in our phagocytosis. All right, so we mentioned the segmented neutrophil has those pinched nucleus, forms those filaments. So if you're ever questioning whether it should be a segmented neutrophil versus a band, and you could see those filaments, it will always be a segmented neutrophil. I tend to lean on the side of the segmented neutrophil rather than a band. So if I'm ever questioning, I will probably more likely call it a segmented neutrophil. Again, there's subjectivity in cell identification, like I mentioned. So typically, in our segmented neutrophils, normally you'll have about 3 to 5 lobes. And when we say lobes, we're talking about each one of these that is separated by the filament. So this is a lobe. Here's your filament. Here's a lobe, filament, lobe, and then you could call this a lobe. You have to think about how these cells land on the slide too. All right. So is this a filament right here and it's just folded on itself? All right. That could be the case too. So this is definitely a segmented neutrophil, segmented neutrophil, segmented neutrophil. They typically have about 3 to 5 lobes per cell. Now there is a anemia, megaloblastic anemia has abnormal DNA synthesis. They will have hypersegmented neutrophils. Very common to see about 5 to 7 lobes per cell. All right. So if you see Consistently, I think you have to have about 50% of hypersegmented neutrophils. You might want to see if that patient has megaloblastic anemia. Okay? But for normal situations, should have less than 5 lobes. And again, look at your chromatin clumping in that nucleus. Very condensed, very dark. Right? And then you do have the presence of your characteristic neutrophil granules. All right, so here's that band versus seg controversy. Most will say if you cannot visually see a filament, call it a band. All right, so look, these are all bands right here. Notice you do not have any visual filament. It takes on that typical C or S shape. Right, when it takes on the S shape, that just means it's kind of folded around. Right, so these are bands, and these are segments. Notice that sometimes even in the segmented neutrophil, you might not be able to see the filament, but it kind of looks like it's folded on itself. Hence, that's why it's a controversy. Would you call this a band or a seg? I would call it a seg because it kind of looks like there's a filament behind this little fold right here. And again, it won't make that big of a difference in your patient diagnosis if you don't have greater than 5% bands. Okay. Now, if you're consistently seeing these, you know, and you have 10 to 15%, you might want to check and see an infection might be present in that patient. Okay. All right, so take a look at this one. What would you guys call that one? That's a banded neutrophil, yes. What about this one? Segmented neutrophil. All right, so let's just review our normal blood cells that you see in peripheral circulation. You have your segmented neutrophil and your lymphocyte. All right, so notice the one on your left is a segmented neutrophil versus a lymphocyte. All right, so this one's the seg, this one's the lymph. All right, that's a lymphocyte. Notice, take a look at that lymphocyte. Very condensed nucleus chromatin clumping. It has the most distinct nucleus clumping of all the cells. All right, what else does it have? Most of the cell is comprised of nucleus, right? It has a very high nucleus to cytoplasm ratio. But take a look at your size. It's relatively the same size, maybe just smaller than your neutrophil, all right? But so it's definitely not a blast. So a lot of students have a hard time differentiating a lymphocyte from a myeloblast. Lymphocytes are smaller in size, and they have this very definite nucleus chromatin clumping. All right, so don't put a lymphocyte in your field of view and try to tell me it's a blast. If it has this very dark nucleus, it's not a blast. All right, and we're going to do some side-by-side comparisons, a blast versus a lymphocyte. All right, here's our basophil. Notice that it's a basophil, takes up the stain. All right, so it has very prominent purplish granules all over. All right, so much so many granules that you can't see the nucleus. There is a nucleus in there, segmented nucleus, just like the neutrophil, but there's so many granules you can't see it. Okay, that's your basophil. And students in lab, you'll have to find me a basophil and make sure you can identify it. What's the reference range for basophils in our peripheral circulation? Yeah, 0 to 2. All right. So you can imagine it's going to be difficult to find a basophil. Some people say it's like finding a unicorn in the forest. Very hard to do when you're looking for it. So, all right, but that's a basophil versus our eosinophil. All right, also has a segmented nucleus, often bilobes. So in this eosinophil, often has only 2 lobes. It has those very orange granules, very distinct. You'll know what eosinophil when you see it. It'll jump out at you, that orange granules. And then here's our monocyte. That picture is horrible, but it has a very lacy chromatin and very grayish cytoplasm. So any of you guys ever have problems differentiating colors? Okay, good. So we pay a lot of attention to the way the cells take up the stain in hematology. So the monocyte cytoplasm coloration oftentimes is a distinguishing factor for the monocyte. Often has that gray cytoplasm. Okay.
So you said it's often not a basophil and so many granules you can't see anything else.
Right.
Okay.
Those granules will be so prominent, that's like the only thing you'll see in the cell pretty much. You won't be able to tell there's a nucleus under there, but there is. Right, and then your eosinophil has a nucleus too. It is oftentimes bilobed, but I have seen an eosinophil have 3 lobes. So it's not abnormal, just most oftentimes that eosinophil is going to have 2 lobes. All right, so here's our eosinophil, and again, lymphocyte. The main purpose of our lymphocyte is it plays a role in immunity. So remember we talked about once those lymphocytes are stimulated, they will transform into a plasma cell. They're going to be involved in building our antibodies to help our immune system. And you guys in immunology, you will study a lot about lymphocytes. All right, and the nucleus is round to oval. It has the highest nucleus to cytoplasm ratio, again, other than that blast. All right, so notice that the cell is mostly comprised of nucleus. You can hardly see any cytoplasm, only barely along the edge right here. All right, so that's your cytoplasm. Everything else is nucleus. And notice how condensed that nucleus chromatin is. Okay, this is a lymphocyte. Sometimes in lymphocyte you can see nucleoli, right? Oftentimes the cytoplasm is blue and it can have granules. There is a condition, any of you guys ever seen or heard of infectious mononucleosis, mono? All right, so one of the characteristics diagnosing infectious mononucleosis, you're going to see a lot of atypical lymphocytes. And that's what we'll talk about them. They have special characteristics. They're lymphocytes, they have granules, they often have a ballerina skirt, okay? And that just means they've been stimulated. They are reactive. They're called atypical reactive lymphocytes. All right, so some of our lymphocytes may have granules in it. It's not abnormal, okay? Unless you have about 50% of them, and then you might suspect infectious mono. So we talked about during our white cell maturation and our pluripotential and multipotential. Remember that the multipotential cell is either going to go the myeloid line or the lymphoid lineage. And we talked about our myeloblast. There's also lymphoblasts, right? So the lymphocyte is going to be derived from your lymphoblast and your prolymphocyte. And this gets tricky because your lymphoblast and your myeloblast, they often will look similar in appearance. Oftentimes, if you think you have a blast on your peripheral circulation, oftentimes we just call it a blast. All right, we don't try to differentiate between a myeloblast and a lymphoblast. Just because with our staining techniques in our eyes, they have such similar characteristics, we can't distinguish, so we just call it a blast. Now we can kind of look and see what other cells are present. If there's a promyelocyte present, then we might, think they're myeloblasts, but again, flow cytometry plays a huge aid in that. And when we start thinking about our leukemias, we have some special cytochemical stains that we can use as well, and we'll get into those when we get into our leukemias. But let's say your patient has acute lymphocytic leukemia, the presence of lymphoblast in the peripheral circulation, that is not a normal circumstance, all right? So it's not normal to see lymphoblast in the circulation, only in the presence of a malignancy in the bone marrow.
So over 50% will be in the circulation, 50% of the lymphocytes.
For your normal range?
Right.
So atypical, yeah. So it is common to see some. I mean, you might see 1 or 2. Like, okay, so any of you guys ever draw my blood and you're going to look at my blood in lab? I know I have atypical lymphocytes on a normal basis. That's just my normal. I don't know why. So I have lymphocytes that have some granules in them. Some of mine do look atypical. It's kind of difficult for identification, but they're just lymphocytes. All right, so the concern would be if you had an increased number of those cells. And again, I talked about how lymphocytes are often confused with the myeloblast because of that high nucleus to cytoplasm ratio. Most of the cell is comprised of the nucleus, so you have to look at your nuclear clumping on that, or in your cell size. The myeloblast is going to be very large. All right, so our normal circulation lymphocytes, you should have about 20 to 40% lymphocytes. So 50 to 70 for your neutrophils, 20 to 40 for your lymphocytes. So those are our two most common populations of cells seen in a normal condition. All right, so we talked about B lymphocytes and T lymphocytes. B lymphocytes will transfer into plasma cells when the lymphocytes are stimulated. We cannot visually detect between B cells and T cells, okay? So they're just lymphocytes. We don't know. There's no way we can visually tell the difference between a B cell and a T cell, all right? All right, here's our monocyte. Notice that it has that, and this picture is not very good, I apologize, but it does have this lacy chromatin, that light gray cytoplasm. And that's one reason you're not seeing it very well on this image, because it's so light gray. Right, but here's your nucleus, and then here's your cytoplasm. And these cells tend to be a little bit larger in size. And they will process the antigen, present to lymphocytes, and they are also involved in phagocytosis, any type of debris or trash. They kind of, I like to say they eat it. So they kind of engulf it to get rid of it. You might describe these cells as scavengers because they will eat that trash. All right, so these guys are going to, when they travel to the tissues, they're going to become macrophages. All right. Remember I said they're larger in size, so they're the largest cell that will be normally seen in our peripheral blood. And the nucleus, sometimes indented, it can have like brain-like convulsions coming out of it. So oftentimes you might see it folded on itself. It might be like, you know, all contorted, right? So that's very common for monocytes. And again, it has that very fine chromatin. And usually no nucleoli present though. And again, very characteristic, that light gray cytoplasm. One hugely characteristic of monocytes is you may see vacuoles present in the monocytes. And it's one thing that's a known side effect of using the EDTA as an anticoagulant. If you don't make that blood very soon after collection, the monocytes will vacuole. So, and then also because they're involved in phagocytosis, you'll have the formation of vacuoles, them getting ready to engulf trash or debris. You can. It's a known side effect. So we really, and we're going to talk about this, really try to make your smears within 5 to 6 hours from collection at room temperature. You don't want them to sit around because you're going to have some artifacts form, and it could interfere with your evaluation of the smear. All right, so just like our monocytes, remember it is in the myeloid cell line, all right? So it's included in the granulocytes, the erythrocytes, and then your macrophage line, right? So it has monoblast and a pro-monocyte as its precursor cells. All right, so your monocyte should be about less than 10% normal range. And again, that color of cytoplasm is very important. Oftentimes, if you take a look at the nucleus, what other cell does that often look like? A banded neutrophil. So to differentiate a monocyte from a banded neutrophil, you have to look at the color of cytoplasm. Remember that monocyte is going to have the very gray cytoplasm. Your neutrophil is going to have that characteristic pink cytoplasm. All right, so color, that's why I asked if any of you guys had any problems differentiating colors. All right, so in cell classification, you want to take a look at the coloration of your cytoplasm as well. All right, so these are some examples of monocytes. All right, notice how the nucleus, fine chromatin clumping, and then again that gray cytoplasm. Both of those are monocytes. All right, so a lymphocyte versus monocyte. You can use size as a good comparison for this. Remember that the monocyte is the largest cell in normal circulation. So this one is your monocyte. And then what is this cell? That's your lymphocyte. Look at that nucleus clumping. That is a dead giveaway. All right? So that is your lymphocyte versus monocyte. Probably won't have, you might have a little trouble at first differentiating lymphocyte from monocyte. But once you get that nucleus clumping down that lymphocyte, you'll be good.
Is it just in this example that there's more cytoplasm in the monocyte and the lymphocyte? Or is that common?
No, that's very common. And why is that? Because the lymphocyte has a high nucleus to cytoplasm ratio. The majority of your cell in a lymphocyte is going to be comprised of that nucleus. It is not uncommon for you to see a lymphocyte and you cannot see very much cytoplasm at all. You might have just a very, very small perimeter around that nucleus. Okay? Very characteristic of a lymphocyte, that high nucleus to cytoplasm. But again, very condensed clumping of the nucleus. All right, so here's our band versus mono. This might give you guys some trouble when we go in lab, right? So notice, want to look at your color of cytoplasm. Which one's the band? This is your band. Good job, you guys. This is band. This is mono. Why did you classify it that way? So you have the C or S shape of your band, right? And then the color of your cytoplasm. I apologize, the screen is very hard to tell. But this is your band and this is your mono. And notice, it might be hard to tell on this image, but you remember the monocyte nucleus likes to fold on itself, likes to convolute. So you can kind of see how the nucleus is folded right here. That's the edge of the side of the nucleus. Okay? And you guys will get to look at these cells in lab today, so it'll kind of reinforce what we're talking. Not the immature ones. We don't have to do immature today. We'll start out with normal, right? So
would the bands be darker colored blue, like the nucleus would actually be darker colored?
yes. And that's another thing you could look for too. Your band has a more condensed nucleus clumping, right? Your monocyte is more fine chromatin clumping, right? So can you see the difference? Very condensed clump here, a little more fine here. All right, so you have the color of cytoplasm, condensation of your nucleus chromatin. Does that make sense? I think I'm almost done, Lindsay. All right, so the eosinophil, the main purpose, evolved in immunity and fighting parasitic infections. It will respond to inflammation and then fighting allergies. Again, that proliferation is the same as our neutrophil, all right? So it's going to start out as the myeloblast, the promyelocyte, the myelocyte. At the myelocyte phase is where those eosinophilic granules will start to appear, all right? The specific granules. And typically the nucleus is going to be bilobed. Remember, it's going to have two lobes. So your normal range for eosinophil is usually like 1 to 2%. Right? So you really can't diagnose somebody having a low eosinophil count, right? So we really only worry about having an increased eosinophil count. And if you saw like 15 to 20% eosinophil, you might need allergic reaction, parasitic infection, something like that.
So it's those, the lymphocytes, and then the neutrophils. If they're high in number, then you probably have an infection.
Yeah.
Would that count for autoimmune diseases as well?
Autoimmune diseases, I would be more, for autoimmune diseases, you think about inflammation, such as lupus, and things like that. So you would probably, you would not see eosinophils or basophils. Neutrophils will respond to inflammation. Well, eosinophils will too. It's not a clinical finding that we usually see though associated with inflammation. Only neutrophils. Lupus typically doesn't affect your CBC findings, like inflammation. Now, depending on what type of inflammation. So if you think about when you cut yourself, or you have some type of wound and it gets inflamed, it's infected, it's inflamed, your cells are going to respond to that. Number one, neutrophils for sure if it's an infection, and eosinophils will play a role as well, but not as much as those neutrophils will. All right, so it depends on what type of inflammation is present. I should say that. Now, if it's a autoimmune disorder due to inflammation, I don't think we'll see too many eosinophils. All right, so this just illustrates the characteristic orangey granules of your eosinophil. Notice the bilobe nucleus, notice the orange granules, all right? Versus your neutrophil, it has a more pinkish coloration to the cytoplasm, and then the secondary granules are very purplish. Right? Does everybody make sense? So this is a segmented neutrophil, eosinophil. Right? And then what cell is this? That's a lymphocyte. Yes. All right, so our basophil is involved in cell-mediated immunity. It interacts with one of our immunoglobulins, IgE. And again, it has the same maturation sequence as our basophils and our neutrophils. And those granules are huge, dark blue, even some might, I call them purple. You might describe them as black, just depends on how you interpret the color. But the thing is, they're so prominent, they will cover that whole cell. And they contain histamine. So they'll kind of be, they also will kind of respond with eosinophils in response to allergic reactions. They're kind of like a backup to the eosinophils. And again, same thing as eosinophils. I mean, we have like 0 to 2% in normal circulation. So you're not going to see somebody with a low basophil count. It's only when we have it increased, when we have that basophilia. All right, so here's your basophils. We're looking at those prominent purplish granules, right? In this cell, you can actually kind of see the nucleus there. Right, can you guys see that? Here's your nucleus right here. And then this one is a basophil too. It has so many granules on it that you can't really tell much characteristics of the nucleus. All right, so there's some other cells that you will see in your CAR atlas and that you will observe in bone marrows. These guys are only found in bone marrow. We talked about the megakaryocyte. This is the precursor to our platelets. We talked about the plasma cell. After our B lymphocytes are stimulated, they will transform into plasma cells. We have macrophages that are located in the bone marrow and also in our spleen. And then we have some structural cells such as reticular cells, fat cells, osteoclasts and osteoblasts, which is normally found in bone marrow as well. So the megakaryocyte, the main function is to produce platelets, which is platelets are the first to respond in the event that you cut yourself. They will be the first ones to respond to the site of injury of that vessel. And they will activate the platelet system or the coagulation system, which we will get into at the end of this course. The megakaryocyte is kind of different in its maturation sequence in that the blast is smaller than the mature cell. So remember I talked about one of our myeloproliferative disorders where you might see some micro megakaryocytes present on that cell, on that slide. Megakaryocytes are huge. You can see them on 10x when you're doing a bone marrow evaluation. And I have a picture right there. So this is your megakaryocyte. Notice it kind of has a folded image, very large in size. And look at this. What do you think this is? Platelets pinching off the cytoplasm. All right, so this megakaryocyte is actively producing platelets. All right, so that's very common to see. And again, you can see we'll be able to do a megakaryocyte count, but when we do our bone marrow analysis, you should have about 1 to 4 per low power field. The megakaryocyte has a maturation sequence, megakaryoblast, promegakaryocyte, and then the megakaryocyte. You guys don't have to worry about identifying megakaryocyte in its precursor forms. Usually if we see it on a bone marrow, we just call it megakaryocyte. All right, plasma cells, main purpose is to make antibodies. All right, so that B cell is going to become a plasma cell. Sometimes you'll have plasmablast, proplasma cell, and then the plasmacyte. So the mature plasma cells, nucleus, oftentimes round and eccentric shaped. It has very clumped chromatin, and the cytoplasm is dark blue with a pale perinuclear clearing. And here is your plasma cell. All right, so here it has the nucleus is eccentric, right, usually off to one side, and here is your perinuclear clearing right here. And some people like to describe this. Any of you guys ever dropped an egg in a skillet? Oftentimes described as a dropped egg. All right. So the yolk of the egg would go to one side, and then the white of the egg kind of spreads out, right? So sometimes it's described as that, if that helps you remember what it looks like. But this is your plasma cell. Notice you have condensed chromatin clumping, kind of have that eccentric shape and that perinuclear clearance while we look for a plasma cell. Again, this is not normally seen in peripheral blood. This would be only in bone marrow. And then here's another example, a little bit smaller. And then here's an example of how it landed during the slide making process. Really not eccentric nucleus, but it does have the perinuclear hazing all the way around it. This is a plasma cell. How do you differentiate a lymphocyte from a plasma cell? You look for the perinuclear hazing. Remember, because this used to be a lymphocyte. It's typically just a stimulated lymphocyte that has transposed into a plasma cell that is now building antibodies. Okay. All right, so then we have our macrophages, and again, its purpose is immunity, phagocytosis, and the storage of iron. So remember we talked about the spleen? There are macrophages in the spleen, and they are involved in removing the red cells, right? And so the body is going to try to reuse whatever it can. So those macrophages, after engulfing those red cells, now contain what? Iron, right? So remember we talked about the iron-laden red cells in the bone marrow? So that is one way the red cells can attain iron is from these macrophages after red cells have been engulfed. You will probably never ever see macrophages in the peripheral circulation. I don't even think it's possible. So it has a very small nucleus, large amount of cytoplasm. Definitely will have vacuoles in it because it is heavily involved in engulfing. Osteoclast and osteoblast, you might see these when you do bone marrow analysis. Osteoclast, think of clast as involved in destroying bone. So osteoclasts break down bone, and as the bone is broken down, osteoblasts are involved in rebuilding the bone process. Right? So you guys know your bone breaks down and it rebuilds up. That's why calcium is so important, vitamin D is so important for your bone rebuilding process. All right, so you will see these in your bone marrow. Notice they're very odd. They tend to, clasts tend to form in clusters like this. But we don't count these. We don't really pay attention to these. They just might be there, or you might encounter them. And then osteoblasts. Just something you might notice. But you should never see those in peripheral blood circulation. All right, so in your lecture manual, you have this little chart. It kind of lists all of the cell lines and helps you understand when you're classifying these cells what to look for, right? So we want to look for our nucleus to cytoplasm ratio. Right? Notice when we start with our most immature myeloid cell, the myeloblast, that nucleus to cytoplasm is high. And then as that cell matures, it decreases. Right? So remember our segmented neutrophil, we're going to have a lot of cytoplasm. Most of that cell is cytoplasm, very much nuclear condensation. Right? And then nucleoli, remember in our most immature cell, we'll have the most nucleoli, 2 to 5 in our myeloblast. And then as that cell matures, those presence of nucleoli also decreases with that myelocyte. The first cell, we should not see any nucleoli. The myelocyte is the first cell that you won't have any nucleoli. However you want to think about it, however you want to remember it, the promyelocyte is the last cell to have nucleoli. The myelocyte is the first cell not to have nucleoli, whichever helps you remember however you said it. And then granules, remember that the myeloblast typically does not have granules at high nucleus to cytoplasm ratio. Most of that cell is comprised of nucleus, but the nucleus chromatin clumping is very, very fine. It's not going to have any condensation at all, so it won't be dark at all. It's going to be very fine. You can also think about size. So as the cell starts from very immature to mature, it's going to decrease in size. Also, the nucleus is going to decrease in size, and it'll even change shape for our myeloid, our neutrophil lineage. And then the chart down here just kind of further what we normally see in peripheral blood versus what we see in bone marrow. So do we normally see plasma cell in peripheral blood? No. Do we normally see macrophages in peripheral blood? What about megakaryocytes in peripheral blood? What about myeloblasts in normal situation? If you see a myeloblast in a peripheral circulation, what should you suspect? Some type of leukemia. Yeah. All right, so we have just a couple things to discuss. We're almost done. The peripheral blood smear. All right, and you guys will actually get to do this in lab next week. The peripheral blood smear should be made within 5 to 6 hours from the time of collection in EDTA. Right, and the reason for that is because the longer it sets at room temperature, there's going to be some artifacts that form. Right, your red cells might start to look crenated, or what we call echinocytes. They're going to start having like a little curvy edge. Right, your white cells might start to have vacuoles. Remember I said the monocytes will start appearing more vacuole than they should, right? Which might think you have a phagocytosis process going when in fact it was just due to artifacts of the section setting too long. All right, so as you guys start talking in topics, you guys will probably think about from the time of collection to when testing should be performed. It's very important when we work as laboratory professionals because that affects the quality of testing that we are reporting out. Right, so you always want to make sure time and temperature of storage. Right, so if you can't test it, maybe you're at an off-site clinic and it's transported to the hospital. Does it need to be on ice? Does it need to be refrigerated? Does it need to be at room temperature? Those are things that, as you go through this program, you will learn about each test. Okay. And to make that peripheral blood smear, we will go over this extensively in lab. You're going to put a single drop of blood on a smear. You're going to use a push smear. You're going to take your push smear and enter it into that drop of blood, and then you're going to push it. And it makes a perfect feather edge. And I wish I had a picture, but I don't. You guys will see it in lab this afternoon. I'll point it out to you because you guys are actually going to load a smear on your slide on your microscope. And so we're looking for that perfect feather edge. And right on the inside of that feather edge, that is where we will do our smear evaluation. We'll look for a good area. We'll examine our red cell for morphology. We will look for platelet morphology and count. We'll do our white cells. All right, so we're going to talk about that in lab this afternoon. All right, and the stain we use in hematology is a Ronowski stain. It's called Reitgensa. It has methylene blue, which is alkaline, so it stains our RNA and DNA like that bluish, dark blue color. All right, and then we have an acetic eosin stain. All right, and it will stain our hemoglobin and eosinophil granules, and it is acidic. All right, so it stains red. All right, so as laboratory professionals, and in this class, we will talk a lot about troubleshooting. What happens? So what happens when your pHs for the stain is not right? What happens if you have too much stain on the buffer? So that can cause alterations in your pictures, and we'll look at this in lab this afternoon. So if you have too much stain and you look at your smear and your red cells are very blue-gray when they should be like a salmon pink color, and your neutrophils are blue instead of their pinkish coloration, what does that mean? And so your slide is more blue than it should be. So what's blue of our stain? The blue, all right? So that means you have too much stain. So troubleshooting ideas, you could decrease your staining time, you could increase your buffering, or you could adjust your pH, all right? Methylene blue is very basic, so you could decrease your pH. And then if your slide is too pink, so maybe your red cells appear too gray, or they're very pale, and then your white cells, you hardly even can tell any cytoplasm characteristics, then you might not have enough stain, so you want to increase your staining time. You might want to increase your buffer, or you could increase your pH. So I will say, when you're thinking about pHs, a lot of these stains are in kits now, and the methylene and the eosin is all in one. And the pH has been automatically adjusted. So sometimes you don't have to worry about pH anymore because it's already figured for you. Back in the old days when we used to have our blue, our eosin, our buffer, and rinse all together, then you have to adjust your own pH. Now with advancements in reagents, typically it's already fixed for you. So oftentimes the only thing you have to do is worry about your timing, all right? And we'll talk about timing in lab 2 on Monday. Does that make sense to everybody? Kind of, sort of, maybe. All right, so I took this image from your CAR atlas. If any of you guys have your CAR atlas, this just further differentiates what cells are normally seen on the peripheral smear, and this is what you guys are going to look at today in lab. You're going to look at these normal cells. We're going to find a good area on a peripheral smear right in that feather edge, and we're going to find these cells. And we're going to do microscope care as well. And that's really all we're going to do in lab today. Kind of just a getting to know my microscope. How do I load a slide? How do I focus? Color illumination. We're going to do all of that. Make sure you guys keep both eyes open. All right, I don't want to see this. All right, you guys all probably have microscope experience, so maybe it won't be a big deal. But sometimes students have a hard time looking in the microscope and keeping both eyes open. All right, so we're going to focus on that this afternoon because hematology involves a lot of microscope work. All right, so we will use the bulk of your microscope use will be in this class. So you'll have to have your microscope pretty much every day. All right, so what did we talk about? Lecture 2. We talked about leukopoiesis. We talked about the maturation sequence of our myeloid line, all the way from the myeloblast, your promyelocyte, your myelocyte, your metamyelocyte, banded seg to the segmented neutrophil. All right. We also talked about the eosinophils, the basophils, the lymphocytes, the monocytes, all of our normal cells that we see in peripheral circulation. We talked about some characteristics that are very important when you are classifying cells, whether you're trying to distinguish between a promyelocyte and a myelocyte and a metamyelocyte. All right, so make sure you review those nucleus to cytoplasm ratios, presence of nucleoli, color of cytoplasm, size. Right? You will use those on a daily basis in hematology when you're classifying cells. Okay? And it'll become second nature to you. It'll become a point where you forget what you're even looking at. You're just like, oh, that's a blast, or that's a pro, or that's a myelocyte. All right. But at first, you're going to have to really stop and think about it, look at images, compare, contrast, and so that's the learning process. Okay, and that's what we're going to do in lab. That's what we're going to focus on. And then we talked about the right stain. We use our Romnowski stains. Right Gimsa has methylene blue with the addition of eosin. Okay. All right. Anybody have any questions? All right. Lindsay, did I take too much time?